Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
Welcome to this week's episode of Life in Sirens. Today we're going to be exploring the latest standards for treating sepsis in the pre-hospital setting. We're going to discuss updated guidelines, critical care transport considerations, and innovative strategies to improve outcomes for the septic patient.
All right, so if you want to kick it off on the next one?
Yeah, let's talk about the importance of early recognition. Real quick, I just want to highlight that studies show that for every hour of delay in antibiotic administration after the onset of sepsis symptoms, your mortality increases by nearly 8%.
Wait, so you're saying that if you have a short transport time, that antibiotic administration still matters?
It's almost like it does.
Wow.
There is a common misconception and idea in EMS that if you don't see the results in transport, then you shouldn't do it. That is disturbed and flawed thinking.
If you apply that logic to any other field of medicine, it doesn't really make sense.
No.
If your PCP doesn't prescribe you high blood pressure meds because they're not going to immediately see the change, they're just not going to do it. Then EMS isn't going to control that pressure because they might not see the change initially either. And then the ER is going to say, well, we're going to admit you, so we're actually just not going to do anything until you get up to the floor. And then the floor is like, well, you're going to have outpatient surgery tomorrow? So we'll probably just let it ride until then.
How weird.
And then you get there and they're like, well, you got to start over because everything is bad.
Yeah, because turns out we can't do any of the things that we need to do because none of the things that had needed to be done have gotten done.
Right. So if you apply that logic to any other field of medicine, it falls apart really fast.
Yeah, I'm very serious about that. It's okay to do things even if you're not going to see the results immediately. If you get a shot of Rocephin in the ER in your booty, they gave that to you because it's eventually going to work. It's going to work right this second.
How many times have you had patients that represent working in an ER? They'll represent the next day and say, my medicine's not working. And you're like, what medicine is it? And they're like, doxycycline. I'm like, well, that is because it takes a minute. But you still prescribed it.
Absolutely. Like Aubrey said, we are going to focus on updated guidelines, fluid resuscitation strategies, and especially focus on critical care transport teams and optimizing those outcomes. Like we've said, early intervention matters.
Right, so talking about sepsis, it's a life-threatening organ dysfunction. It's caused by the dysregulated host response to infection. And so the patho...
You have a widow infection that gets inside your body. It says, love it here. I'm going to explore more. Got to get on the subway. Gets on the blood subway.
So with sepsis, there's different kinds of severities of sepsis. So we're going to talk about septic shock. And in the patho, you have to have an infection source to be considering septic shock. And so it can be an infection. It can be bacterial, viral, fungal, or parasitic. So pathogens or their toxins activate your immune system, and that is going to cause systemic inflammation. This immune response becomes dysregulated. And so there's these little messengers that run all through your body, and basically they tell your immune system, like, hey, you need to come here, do the things. They're called cytokines. So when cytokines there's too many, or they're everywhere, you call it a cytokine storm, and that can lead to widespread vasodilation, your capillary leakage, and microvascular thrombosis. So your cytokines basically have been like, And then
Just like that.
horrible things happen. So the circulatory abnormalities that you experience, you're going to have hypotension from both vasodilation, but also increased vascular permeability. So you're basically going to have third spacing of your fluid. And then because of all of that, you have reduced tissue perfusion, and that leads you to hypoxia. And now that you have reduced perfusion and hypoxia, now none of your organs or any of the things that are important to your body are really being perfused. You're going to go into an anaerobic metabolism, and that's going to increase your lactate production. Eventually, this will get you to MODS if there is no intervention.
Okay, but how many people does this really affect a year?
Stop downplaying everything, Aubrey. Gosh. It's 1.7 million people in the U.S. annually.
Well, my God, we should talk about that.
And 270,000 deaths.
A year?
Yeah, per year.
Man.
So early recognition is so important. Calling your code sepsis, intervening in the field does matter. Just because you may have a 30-minute, 15-minute, 10-minute transport does not mean you shouldn't be intervening, because they may have been having symptoms for 3 days and you're already so behind.
Recognizing sepsis early in the field is like catching a spark before it becomes a wildfire.
Ooh, I like that.
So let's talk about some updated pre-hospital sepsis treatment guidelines.
We'll post on our social media where we obtained all these sources if you are a nitpicker and would like to find those.
So we're going to talk about some updated pre-hospital sepsis treatment guidelines. Obviously, there is a huge stress and importance of beginning treatment. Well, one, recognizing that sepsis is on the differentials, and then beginning treatment in the field. Just like with traumas, we have like a golden hour. You can have that same thought process in sepsis as well. The faster that you get treatment started, the higher likelihood of a good outcome. So we all know fluid resuscitation is huge in sepsis. LR is typically recommended over normal saline in these situations. I know that the 20 mLs per kg is like drilled into our heads for literally every kind of fluid resuscitation that we do, but actually with sepsis, you're going to do 30 mLs per kg of that LR. If you have any antipyretics, you can give those. If you have antibiotics on your truck, which is pretty cool, you can give those. And then norepi is a great pressor. In sepsis, there is more of a push to initiate a pressor along with your fluid resuscitation, and usually the pressor of choice, well, always the pressor of choice in sepsis is going to be your Levophed, your norepinephrine.
With pressors, if you think about your pathophysiology of your sepsis, so you have a dilating vasculature that has now become semi-permeable. And so not only do you have third spacing, but so you've gotten a leaky tank and a big tank. And so the reason that pressors has become so important as like a first line treatment is that not only can you really not fill the tank, but it's huge. So you're trying to fill it with fluid, but it continues to leak. And so pressors are going to make your tank smaller. And so as you fill with fluid, you're going to lose less, if that makes sense.
Studies even indicate that pre-hospital administration of antibiotics can reduce mortality by 30%.
That's crazy.
That's not small.
No, guys. Just because this is, again, soapbox. Please just give the medications that are indicated and are appropriate. That's all I could beg of you.
So in EMS, what are some criteria that we're going to look at that is going to lead us down a differential that is sepsis?
Well, fever, tachycardia, hypotension, infection source, or any patient with a condition that causes immunosuppression, patients who have central lines, patients who have Foley catheters, any patient who has something in their body that isn't technically supposed to be there. A lot of patients who are bedbound, sacral pressure ulcers, things like that. Sometimes a lot of these sources of infections can be hidden, so just keep that in mind. Quick trivia. What do you think your end title is going to be in sepsis? The answer is
Low end title.
correct.
So if you have a patient that has any of these findings, so you have a potential infection source, they're immunocompromised, they have foreign devices inserted into their body, and they are tachycardic, you get their end title, it's low. What are the three things that you will see that you are really concerned about and sepsis puts really high on your list that are actually really easy to see.
Altered mental status.
Altered mental status, an elevated respiratory rate, and hypotension. And then you start looking at some of these more complicated measurements, like end tidal. And by complicated, I mean very simple.
And just keep in mind, too, that sometimes your patients who are beta blocked may not be tachycardic. Same thing goes for your trauma patients, you know?
Yeah, which is just the story of EMS, that you learn all of these signs and symptoms, and then they're like, but the people that are the most likely to have this condition are also going to be geriatric, and they're going to take a bunch of meds that make them not present the way that you're taught that they will.
100%. So, on your basic ALS truck in the field, what are we going to be doing to provide intervention that is pretty simple but necessary? So in pre-hospital, we're going to provide, like, the number one thing I think that we're going to need to provide is the fluid resuscitation. This is so important, even with, like, minor hypotension. A lot of the times we need to give fluids because there are things going on in our body that also require fluids to wash them out, such as that increased lactate. So we need fluid resuscitation, even if we're not profoundly hypotensive or tachycardic yet, because we're going to get there if we don't intervene. So I think most systems and most EMS systems, their sepsis protocols are going to look like an antipyretic, if they have it. A lot of systems don't, which is sad. And then fluid resuscitation, IV access, and if your service does this, draw labs, and then call the code sepsis. I think that's kind of, unfortunately, that's the bare minimum, and that's what we see.
That's traditionally what you'll see people carry. So if you move more into a critical care transport setting, and this may still be a, like, 911 service that just has some more resources, what is that going to look like?
Well, I think for critical care, we're going to focus pretty heavily on, you know, those more complex hemodynamic instability interventions, including pressors. I know a lot of non-critical care services will pretty much have, you know, dirty epi. There's not really any other option, if they even have that in their protocols. So vasopressors are a big one that you're going to see in critical care. I think you're almost always going to see the antipyretics, and possibly you're going to see the antibiotics, especially if you're doing those interfacility transfers or flights.
If you are attempting to improve profound hypotension, what's your goal? So you're given fluid, you are giving norepi. What's your goal? What's your measurement?
Well, for now, and what we have available to us, the goal is to maintain a MAP of at least 65. We're not super worried about a certain systolic or diastolic. We just want to hopefully maintain a MAP of 65. So if you're super concerned that your patient has a, you know, systolic of 90, just take a deep breath. What is their MAP? Let's focus on MAP. That's one of the best, or the biggest and most, like, memorable advice I ever had. JP was like, it's okay, just focus on the MAP. So focus on the MAP. Maintaining that MAP is important. So don't freak out over low blood pressures as long as your MAP is appropriate.
And remember that numbers and tools are only as good as the provider using them. So pay attention to your actual patient.
Please take a manual.
Right. And if you have an improvement in mental status, you're heading the right direction. If you have an improvement in your end tidal or a decrease in your respirations, or maybe they're still tachycardic but less tachycardic.
Yep.
Things like that. Even if your numbers still aren't to a place that you're super comfortable with, improvement is kind of where you want to lay your focus.
And in most cases, you're probably going to see improvement with fluid administration. Obviously, in those more severe septic shock patients, you're already behind, and that can be a lot harder to mitigate. But oftentimes, we're going to see that improvement with the LR administration. So let's talk about real-world applications and examples.
So let's say that we have a 70-year-old male. Family is called because they are concerned about him. He has been laying in bed. This morning that they noticed he is more altered than normal. He does have a Foley cath that he has chronically. They've noticed that he's hot to the touch, confused, lethargic. They couldn't get him up to eat breakfast. You get a set of vitals. He is tachycardic. He is mildly hypotensive. You're on your that day, and you get an end title. He has an end title of 18.
That's pretty bad.
It's pretty bad.
Isn't a bueno.
It's not great. He is febrile at 102.7.
Tympanic.
Tympanic. Tympanic means you need to panic.
Oh my god.
That's what I always say. No, just kidding.
Yeah, we hate tympanic thermometers in EMS because it's really just letting you know what the average temperature is between the environment and the patient.
Correct.
Yep.
Correct. So with this patient that we've described, what would be your first steps?
With a patient that presents like this, I think the first thing that I would do with a chronic Foley, that's our most likely source of infection. So I will inspect. Ask the family, has our urine output changed? Do you have any like chunky things in the tube? You know, all our favorite parts about
Do you
Foley
have any
catheters.
debris?
Is there any debris in the tube? Things that we don't love, but we all have witnessed in a Foley catheter. I will look at that and be like, this is probably our source of infection. You can look at the insertion site and see if it's like red or oozing or anything like that. Identify your possible source of infection and then move into our treatment. And what does that look like?
Well, it's too bad that you didn't make sure that your scene was safe and you got attacked by the dog.
Oh my gosh, you're dead.
But let's just say you fight off the dog and you make
No,
it to
she
the ambulance.
I died and then fought off the dog.
Well, you did not see.
You resuscitated yourself.
Yeah, you didn't put on gloves. You didn't tell me your
Man,
scene
I'm
was safe.
good. I'm good.
You did not take spinal precautions, but we're not even going to talk about that.
I didn't even consider it.
You didn't even consider it. So we get to the ambulance. You have identified your suspected source of infection. We've already established that he is febrile. He's tachycardic. We have hypotension. We have a low end tidal. Our suspicion of sepsis is up there, right? So the first thing that we want to do is maintain airway, obviously, because medic school.
Absolutely. I'm going to
Oxygenation is
I'm
important.
going to maintain the airway, and if my O2 sat is lower than 94%, I'm going to initiate oxygen via nasal cannula 2 liters per minute to start. But I already have all my nasal cannula because I'm obtaining an end tidal. Secondly, I'm going to start a large bore IV. I'm going to draw labs.
Just one?
Initially. Simmer.
All right.
A large bore IV because I'm going to draw labs, and then I'm going to initiate fluid management. I'm going to use LR at 30 mLs per kilo for my initial fluid bolus. We do have pressors at our system, so I'm going to initiate a norepi drip. Because we are just mildly hypotensive, but
What's
still
the map?
hypotensive. That's 50.
Oh, man.
Oh, my
We're
God.
profoundly hypotensive.
Yeah, my bad. You're not mildly hypotensive.
I'm going to titrate my MAP to 65. So I'm going to start, because we, in this scenario, are mildly to moderately hypotensive. I'm going to titrate my MAP to 65, and I'm going to start like a mid-range of my norepi infusion.
Okay, I like it.
All right. What about transport? Where are we going? You have a local ER, 6-bed ER, that is 15 minutes away. You have a general hospital with ICU capabilities that is 30 minutes away. And then you have a level 1 trauma center that's 1 hour away.
I will take 30 minutes general hospital, please,
B.
Bingo.
for $5.
Here's $500.
Ballin'. Yeah, so why do we want to go to that mid-range hospital?
Well, first of all, if you go to the local ER, they will be so mad at you. They're going to yell at you, and they're going to be like, why would you bring a patient on pressors here? Get out of here. Call the helicopter. It's going to be crazy. But this patient more than likely will need ICU level care, especially depending, which this case does sound like urosepsis, but depending on the source of the infection, there could be other interventions like surgical interventions that need to be performed. And like I said, most septic shock patients need an ICU if they make it there.
Why is the level 1 an hour away not your best option?
We need to intervene as quickly as possible with some antibiotics. If something catastrophic happens at this general hospital with an ICU, then they do have the opportunity to, transfer the patient out, but we will at least be intervening as quickly as possible with the only cure to sepsis, which is removal of the source of infection, and in this case would be an antibiotic.
So I know that we used a very general case study. Like everybody, I hope that we've all seen a case of urosepsis or a UTI, but always remember that sepsis can look like a million different things, right? The flu, pneumonia, even dehydration, that can all lead to sepsis. So when all of those things are on your differential, always keep that in the back of your mind that if this progresses to this point, I'm going to have to intervene in this way.
In our system, with our local hospitals, we have to call a code sepsis. This does not mean, like, in a STEMI situation, you have to be transporting lights and sirens, but we do have a code sepsis system. So if you do need to alert your hospital system, go ahead and do that, especially if you are farther out.
This is a bit of a controversial question. Do you run lights and sirens with this person? Like, do you transport them emergently?
I think this is going to be... we're going to have varied responses to that question because I think it depends on what kind of system you work in. How far are you? If you are out in the middle of nowhere, Montana, and you have a 2-hour transport to the closest facility, you might want to do that. Or if you're in a major city where every block is an intersection and it's rush hour, you may want to get people out of your way. I think provider discretion is important, but for me, in our system, we have about, depending on where we are, a 10-minute to up to 30-minute transport usually. So unless something is going catastrophically wrong in the back of the ambulance that I cannot intervene on, I'm not going to go emergency.
Yeah, I think it's important to remember that if you are appropriately managing your patient and you can intervene and it's not something that you can't help make better and mitigate, that emergency traffic like lights and sirens is not always the best answer, because you have to weigh your patient's safety. So you're intervening medically, basically for their safety, but you have to also make sure that you're keeping yourself, your community, and your patient safe while transporting as well. So you have to weigh your risk versus reward.
And that is why I think the future direction we're headed with sepsis management is becoming a lot more progressive than it has been, which is awesome, especially for those more rural communities, because you can more calmly and casually get this patient to where they need to be, but you're already capable of performing the solution. So I am very excited about that. So why don't we talk about, future directions and innovations in pre-hospital sepsis care? This one is yours, Aubrey, because I know you want this.
I do, man. If we had iStats on the ambulance, I would be one happy little cookie. That's all I have to say. But in all reality, that is happening at some places. So I think that in the future, we will see more and more of that. We'll have iStats. We'll be able to get labs on scene. Some places already do telemedicine. You'll see that a lot in the community paramedicine setting, and some people even do it within their 911 systems. Also, if your agency doesn't already have a vasopressor within your protocols to use, such as Epi or even better, Levo, you will probably see that in the coming years. That's been a big push and a more standard thing to see in the pre-hospital field, especially in sepsis.
And if you don't have a pressor, such as Levo, let's just take a moment to empower you to...
This is your moment. We are going to take a moment to empower you to put the pressor on your administrator. I'm so sorry. This is the moment that we are going to put pressure on you to get pressors on your ambulance.
Bingo.
Put that on a t-shirt.
Bingo.
So what are some key takeaways that we can leave our listeners with?
Early recognition and treatment is so important. Just because you can't see the results now doesn't mean things aren't happening. That's just a golden rule in life, I think.
I think you're absolutely correct. I think we're going to start to see a lot of updated guidelines. Obviously, we already have the timely fluids. Early administration of LR is already there. Hopefully, we will be able to see more use of antibiotics pre-hospitally.
That would be so cool. We
That
have a
would be
local
very cool.
agency that does that, which they do have a significant transport, but I mean, power to them for
Mhm.
adding that. That's incredible.
Yeah, it's very cool.
So some services, especially critical care services, when it comes to identifying sepsis, they are using an iStat, and so they're looking at their lactate levels, which is a good indication of anaerobic metabolism. and you're producing lactate. But they also, not a lot of systems do this, and by not a lot of, I don't know if any do yet.
Not in this country.
No, but you can look at procalcitonin. It's a biomarker, and it can assess the presence and severity of your bacterial infections, especially in cases of sepsis. It is a precursor to your hormone calcitonin, and that's produced in small amounts by your thyroid gland. But during bacterial infections, the production increases significantly in response to systemic inflammation.
That's pretty cool.
Yeah,
It's basically
so
like being able to get a troponin, but in sepsis.
Yeah.
absolutely. It has a high sensitivity to infection. It's abbreviated by your PCT levels, but it strongly suggests a bacterial infection, and it can help differentiate one between bacterial and viral. So you're not just throwing antibiotics at everything, which is great for antibiotic resistance. And it can guide your discontinuation of antibiotics.
That's cool.
So pre-hospitally, that would basically just be like our initiation of antibiotics.
Yeah.
But once you get into the hospital setting, those levels can suggest, one, if it's a low PCT level, that it's unlikely that you have a bacterial infection, or if it's declining, that it's a favorable response to your treatment. So things are getting better, which is pretty cool. So in practice, the ISTAT, some versions support the PCT testing. But again, expense, practicality, amount of use that it would receive,
Right.
things like that.
Maybe more focused on the critical care transport.
Absolutely. But it could be a good utilization for services that have really extended transport times that do carry antibiotics. These could be things that help really target their patient care, which would be quite interesting.
Let's do some sepsis trivia. My favorite part of the episode.
Dun, dun,
We
dun.
do this in
Let's do it.
trivia. I got some questions for you guys. What does the acronym QSOFA stand for in sepsis evaluation?
QSOFA stands for Quick Sequential Organ Failure Assessment.
Terrific. What is the current hallmark laboratory finding in septic shock?
Lactate.
Correct. Let's move on to the next one. What is the recommended initial fluid resuscitation volume for a patient with sepsis?
30 mLs per kg.
Correct. All right, James, this one's for you. I think that you know this.
Uh-oh.
What day is recognized globally as World Sepsis Day?
420.
What?
September 13th.
Good job.
Soph, what famous historical figure is believed to have died of sepsis?
Aren't you glad I went to Catholic school? Joan of Arc.
And why?
I don't know.
It was an infection caused by battle wounds.
Dun dun dun. What a bad.
What a bad.
Man, if only Alexander Fleming had been around. Aubrey, what modern medical advancement significantly reduces sepsis-related deaths?
Antibiotics.
Beautiful.
Well, I hope that sums everything up for you guys. This was kind of just like a quick overview of sepsis. I know a lot of you already know what you're doing and what you should be doing with sepsis patients, but in case you need a refresher, here it is. And I hope we were able to give you some new fun facts about sepsis and the direction it's headed as far as treatment goes.
Well, guys, that wraps us up for today. Thank you for listening to this episode of Life in Sirens. As always, you can follow us on any of our socials, and you can listen to podcasts wherever it is that you listen to podcasts. And remember that during this bacteria-filled season, bacteria is neither friend nor food. This has been Life in Sirens, produced by three nerds trying to bring you content that you might actually care about.